With this, it gives me immense honor and pleasure to introduce our moderator for today. It's none other than Dr. G C Khilnani. Sir needs no introduction. However, sir is the chairman, Department of Pulmonary Critical Care and Sleep Medicine, PSRI Institute. He was the former professor and head, Department of Pulmonary Critical Care and Sleep Medicine, AIMS, New Delhi.
Good evening, ladies and gentlemen, and thank you, Dr. Ketuki, for that generous introduction. And we are in for academic feast, but I would like you to take you into the history, since I am practicing pulmonary medicine for last 40 years. 30 years back, even the Murray and Nadal mentioned ILD as only a simple one disease with corticosteroids as the primary treatment. And ever since, we have come a long way. Today we have more than 200 causes of interstitial lung disease. It has been dissected into the various types of ILD. The CT scans have improved, and also the treatment. And also today we have interstitial lung disease which we managed, and finally lung transplantation has also come in for the rescue. So gone are the days when ILD was a death sentence, that you have only 3 years left with you. And today we are going to unravel all the intricacies of ILD with guidance and assistance from Dr. Stefen, which I had the fortune of listening to him several times in US on American Thoracic Society meetings, and also American College of Chest Physicians, that is called now chest meeting. Although Dr. Nathan is an eminent pulmonologist and expert in the lung transplantation, he did graduation from University of Johannesburg, and then did fellowship in the Jewish Long Island, and also did fellowship in pulmonary critical care and lung transplantation at the Cedar Sinai Medical School at Los Angeles. Dr. Nathan has authored more than 800 publications and chapters in various journals, and also written chapters. Please. So that was a masterly presentation, but before I can I take into the treatment part of the two cases that you have presented? I'll first go to case number 1, which was actually a prospective case. Very rarely we find that kind of follow-up. So that was a UIP pattern, fibrotic. So, Dr. Nathan, at what stage you would have thought it would have been right to start antifibrotics in this patient? Right at the beginning, or in between, or when the symptoms came? That is one question.
Yeah. Let me take them one at a time, because my memory is not that good, and then you can fire with the next one.
No, because the second question should be first. Does that mean that every case of ILD, irrespective of the pattern and the symptom, should have a rheumatological workup?
I'll take that one first. I scratch my head every time that happens, because I don't want to do a rheumatologic workup. I know it's IPF. I'll give you the case I mentioned earlier, 75-year-old male, former smoker, family history of IPF, no connective tissue disease symptoms. Why get a CTD panel? Even if the ANA is mildly positive or the rheumatoid factor is mildly positive, in my mind, the pretest likelihood is so high, that's going to be IPF. But the reason I'll get an ANA and a rheumatoid factor and a CCP is because I know at some point someone's going to ask for it, or if he's ever had it. So let's just get it out the way as part of the baseline labs. Let's get it done, because I know someone's going to question that. But my answer, truthfully, in my heart of hearts, is not every case needs a CTD panel or workup. And I think where resources are difficult, where it's difficult to get labs, if the pretest likelihood is high enough, I don't think that you need to get a CTD panel in every case. Now, if you have...
Sorry, even if it is a female patient?
No. I'll give you the other end of the spectrum. If you give you an example, a 55-year-old female patient, I'll always get a full CTD panel because my suspicion is much higher than that there's going to be a CTD that I don't want to miss. And of course, I've given you the 75-year-old male and the 55 or 45-year-old female. There's a spectrum and a gray zone in between where you have to make a decision on a case-by-case basis. Is it worthwhile? What's my pretest likelihood? And probably most important is, how's this going to change my management? Is it going to change my management? I think for every test we get, we've got to think ahead, especially if it's a more invasive or costly test. Am I going to do anything different based on the results that I get? Now,
second question.
Coming to the second question, when to treat, and thinking about that first case, he had some mild restrictive physiology. He had a UIP pattern. I thought a clear diagnosis of IPF at that time. I would say, even if he had normal lung function, I'm very aggressive about putting them on antifibrotic therapy out of the gate. Now, why do I do that? In my head, I have a survival curve of untreated IPF. And we actually published our own data 15 years ago in CHEST of prior to the antifibrotics of about 500 patients with IPF, and our median survival was 3.5 years, and that's right in line with the literature, anywhere from 2 to 5 years median survival. And so a lot of times I struggle with that because I look at a patient and they're normal, they have a normal lifestyle, they're not symptomatic, and I think, why start them on an antifibrotic and subject them to potential side effects where they look totally normal and have a good quality of life? And then that survival curve comes into my head. And I know the unpredictable course of IPF, and I'm thinking, oh gosh, 3.5 years untreated, there's a 50% chance this patient's going to be dead within 3.5 years. So how can I withhold therapy? And that's the discussion I have with patients. I think you can talk patients into therapy or you can talk them out of therapy. And it depends on how you present it to them. And so there are many different tricks I use to talk to patients about going on antifibrotic therapy, even if they're feeling well. We know that the antifibrotics don't reverse fibrosis. We know that they slow or arrest progression. So the earlier you start treatment, the more likely it is you're going to be successful. And even if you go back to the original nintedanib studies, the impulsor studies where there were subgroup analyses, they did a subgroup analysis of patients with FVCs greater than 80% of predicted and greater than 90% of predicted, so-called normal lung function. And they showed that the rate of loss of lung function and the effect of therapy was exactly the same in those with normal lung function as it was in patients with more compromised lung function. So I don't see the point in waiting in the case of IPF. The earlier you can put them on therapy, the better. I'll finish off this question with another patient anecdote. A patient I saw many years ago, a woman diagnosed with IPF. And by the time I saw her, her FVC was 100% predicted, totally normal. But she herself was a physician. She was an allergist, and she used to calibrate her own spirometry in her office herself. And she knew that her baseline FVC was 120% predicted. Now, if I didn't know that she'd lost 20% lung function, I could have looked at her FVC and said, don't worry, you've got a little bit of fibrosis, but your lung function is totally normal. Don't worry about it. Not everyone starts at 100%. By the time she saw me, she had had a significant decrement already, even though her FVC was still well maintained at 100%.
All right. So so if you do a routine CT scan in 75 years old in males, percentage of cases you would find what we call as interstitial lung abnormalities. So that's the dilemma that we face day in and day out. And another question is that suppose a person you start managing with nintedanib or pirfenidone, and for 1 year his lung functions are stable, his vital capacity is stable. Do you still continue with the treatment, or you say, okay, I've done enough?
The second part first. once I put them on antifibrotic therapy, it's there to stay. I don't think you can ever say, well, the antifibrotic has arrested the disease. They've been on it for a year. I'm going to take it off, because the nature of the disease is such that it's very unpredictable. And it could be that they're going to decline in the second year. And the argument is, I don't think you can ever cure IPF or any progressive fibrotic disease by putting them on treatments for 3 months, 6 months, 1 year. Once they go on drug, it's a lifelong commitment unless they have intolerable side effects. So I never stop the drug. I never stop it if they have stable disease. You can't get lulled into a false sense of security that you stop the disease or the disease isn't of the progressive phenotype. And even if they have progressive disease, I will continue the drug. We did an analysis from the capacity and ascent studies. Those were the pirfenidone studies of over 1,200 patients. And I think this analysis that I'm going to tell you about now was very instructive. 1,200 patients followed prospectively, randomized to placebo or drug, blinded. And we said, let's look at the patients who had a 10% decline in the FVC over the first 6 months, and let's see how they acted and performed over the next 6 months. So there were 64 patients on placebo, 32 on pirfenidone who had a 10% decline in the first 6 months. And then over the next 6 months, we followed them. And in the pirfenidone arm, there was 1 death. In the placebo arm, there was almost 30% of those patients died. The question from that is, yes, you've had a decline in lung function, so there's been progression, but it doesn't mean that the drug's not working. If we had taken those patients off pirfenidone, they would have gone in from the group had a 3% 6-month mortality into the group with almost 30% 6-month mortality. So even a decline in lung function doesn't mean that the drug's not working.
Okay. So now, one other question is, when do you switch from nintedanib to pirfenidone and otherwise? Suppose a patient is there who we start on nintedanib, he doesn't respond for 6 months, his lung function keep on declining. When is the time you think that you must switch to another drug?
There's no good answer to that. If they're on drug and they're declining and they're tolerating the drug, I will keep them on that drug. There's no data to say, well, if they're on pirfenidone and they decline, they're going to do better on nintedanib and vice versa. And I'll go back to the study I just explained or just spoke about in terms of the protective effects of antifibrotic therapy, even in the context of a clinical decline. So you don't want to switch them from pirfenidone to nintedanib because they might be tolerating the pirfenidone and they might not tolerate the nintedanib and vice versa. Now, what about data using the two together? Well, there have been small studies looking at the two together, suggesting maybe that there is some increased efficacy, but certainly much more data showing more side effects and adverse events using the drugs together in terms of GI side effects. So no strong data to support that approach as yet. What's interesting here in the US, and I think it's happening ex-US as well, is that pirfenidone is being studied via the inhaled route, and there are plans to study nintedanib by the inhaled route. So I think that's some exciting developments that we can expect in the future. Can we give these drugs via the inhaled route and maybe the other one systemically? And then you kind of attacking the disease from both aspects, both from systemic absorption as well as via the inhaled route. So more to follow about that, but those studies still need to be done.
So, thank you. So one of the attendees have asked a question about success of lung transplantation in US.
Yeah, so, lung transplant is what I say last resort form of therapy. We want to do everything short of lung transplant. And I wear many hats. I'm a transplant physician as well as an ILD physician. And what I tell patients is my goal ultimately in life is to put myself out of business as a lung transplant person because we don't want to have to do transplants on anyone. And that's where these medications come into play and hopefully more coming down the pike. But lung transplantation is just for very select patients. And the success rate is actually quite good. The 1-year survival here in the US is around 90%. The 5-year survival is around 60%. Now, certainly we hope for better, but many of the patients we transplant are very sick on a high flow oxygen. The way the allocation system works now in the US is that the sickest patients get the lungs first. So I would say that probably about 75% of our transplants are patients who are in the hospital who we simply can't get out the hospital because they're on too much oxygen, they're on mechanical ventilation, or they're on ECMO. So these patients have a prognosis of weeks potentially versus transplant, which can give them a 90% 1-year survival. I think we're getting more aggressive and transplanting more elderly patients as well. I think there's growth in the lung transplant area as we try and recondition lungs. And so, xenotransplants is something else that's been looked at. So certainly room for improvement with lung transplant, but the hope is that medications will delay or avert the need for transplant in some patients.
So thank you. So one of the attendees have asked how long antifibrotics should be continued, and you have already answered that once start they will continue. Now I'm switching gears to hypersensitivity pneumonitis. I'll call it HP. Coming to the first diagnosis, as you know, in India, 43% of ILDs are HP as per the registry. So, what about the transbronchial lung biopsy or cryobiopsy? Does help in your because our pulmonologists have a very low threshold for doing these biopsies for diagnosing HP, although literature probably does not support that.
Cryobiopsies you're asking about?
No, transbronchial lung biopsy for HP.
Okay. I think not as good as a surgical lung biopsy, but certainly less invasive. I think they can be very helpful. If you see non-caseating granulomas, if you see airway-centered inflammation and fibrosis, that's just another piece of the pie in terms of increasing the likelihood that this is going to be chronic HP. So if you have a pretest likelihood where, just by way of example, you think, gosh, I think there's a 2/3 chance this is chronic HP. And then you get a transbronchial biopsy, you see some inflammation around the airways. Certainly, if you see a poorly formed granuloma, that's more information. But after the transbronchial, you might be, well, I was 2/3 certain this was chronic HP. That's given me enough information. Now I'm 90% certain this is chronic HP. So I think transbronchials and certainly a BAL, looking for a BAL lymphocytosis, can give you added evidence on the way to making a diagnosis of chronic HP.
Now I'm coming to another part that is called NSIP, that is non-specific interstitial pneumonia, fibrotic NSIP. Now the standard treatment in our setup that we treat them with MMF, or mycophenolate, or azathioprine along with steroids. Now the CT would assess that there is some amount of fibrosis. So, and while they are on these medications, they do deteriorate. And chronic HP versus NSIP is very difficult to discriminate. That's what our experience says. So at what stage you think that antifibrotic should be added to the treatment?
Yeah, I think very good question that we kind of struggle with as well. And as you know, NSIP can be accompanied by varying amounts of inflammation and fibrosis. And probably the best example would be a CTD patient, because most of the CTD patients will have NSIP, except rheumatoid arthritis, more of them have UIP. And let's say it's an idiopathic NSIP patient. You don't want to miss anything that's potentially reversible. Sometimes you can look at NSIP and say, gosh, this all looks fibrotic, or you can have a lung biopsy that looks like NSIP and it's all fibrotic. And then I'm going to try and put them on an antifibrotic first. But if there's any element of inflammation or ground glass that you think might be reversible, then I think certainly steroids and mycophenolate are the first order of business. So not uncommonly, we'll put them on steroids. We might start mycophenolate out of the gate, or what we might do is just steroids, say 40 milligrams for a month or 6 weeks. bring them back, see if they feel better, see if there's objective evidence of improvement, either on their 6-minute walk and or their PFTs, and then make a decision, are the steroids doing anything? And if they are, then we'll layer on the mycophenolate because we don't want to keep them on high dose too much, and we'll start them, 500 to a gram twice a day and start tapering down the steroids. Now, it's never as keen as that because sometimes you're very uncertain if there's a response or not, and you're left scratching your head and saying, well, the PFTs are stable, or they increased by 50 cc's, 100 cc's, the patient feels a little bit better, but I'm not sure if it's just the steroids. So a lot of times we do continue, if there's any doubt, we'll continue with that same kind of treatment paradigm, wean down the steroids, later on the mycophenolate. And then we have the fibrotic component, and we certainly want to address that as well. So down the road, we'll look to start the nintedanib. Here in the US, the insurance companies are pretty particular in terms of documenting progressive pulmonary fibrosis. And that can be a problem sometimes because if you look at the inbuilt criteria or the ATS criteria, sometimes you have to, quote unquote, play the game in order to get the drug paid for. So you have to see if the patient's having worsening of symptoms, plus minus the CTs getting worse, plus minus the PFTs are getting worse in order to justify putting them on nintedanib. I don't know. I suspect things might be a little bit easier in India to get the nintedanib. I think for any fibrotic lung disease, I would favor it without necessarily showing progression. I'll give you an example. Well, sometimes we see a patient for the first time and their FVC's 60% are predicted and they have more than 20% fibrosis in their lungs, but they're coming to clinical attention for the first time, and therefore we haven't been able to demonstrate progression. But we know they've progressed at some point. So, but we kind of stuck with this definition of progressive pulmonary fibrosis. And so in a situation like that, I'll do what I can to put them on an antifibrotic. I think fibrosis becomes perpetuating at some point, and we can look at the criteria for progressive pulmonary fibrosis, but there is data to suggest that it's the burden of fibrosis that determines further progression. And this comes back to the question about interstitial lung abnormalities and what to do with those patients. Well, that's just ILA. It's just a little bit of fibrosis subpleural reticulation, which isn't a big burden of fibrosis. And there are some patients, and perhaps many of those patients, who are predestined to stay stable for many years, versus a patient who has 20% fibrosis, and that patient, in my viewpoint, is at much higher risk of having further progression and therefore warrants therapy. I neglected to address your question about ILA and what to do with those patients. That's ILA is a relatively newly described entity in the last 10 years. So as we get more CTs, we're seeing more of these interstitial lung abnormalities in 5-10% of the population. What to do about those? And no one really knows. And it's really something to discuss on a case-by-case basis. I would take a very different approach in an 85-year-old male with ILA versus a 50-year-old male with ILA, where I would watch them much more closely, have a discussion about
Yeah, sure. I have to stop you because there's a question from audience. So many questions are my questions. I don't want to dominate that. So one question is, are the chances of redeveloping fibrosis in the transplanted lung?
Generally, the patients don't develop IPF or NSIP in the transplanted lung. What we worry most about in the transplant lung is chronic allograft rejection. And the new acronym, or relatively new, is something called CLAD, or chronic lung allograft dysfunction. CLAD incorporates bronchiolitis obliterans, airway-centered fibrotic destructive process. But CLAD also, there's a restrictive CLAD as well that's categorized by fibrotic infiltrates. But it's not the same fibrosis that we have with IPF or UIP. A lot of times patients will have a viral infection and develop fibrotic CLAD, and it's probably residual fibrotic injury from viral or other immunologic injury. So whether or not these patients with fibrotic clad might be candidates for antifibrotics, I think remains to be determined.
Thank you. And there's one question which is asked from the attendees. Is there any role of antibiotics and at any point of time in these patients, and how and when?
It becomes attractive to think about antibiotics. The erythromycin and azithromycin have been used for their immune modulating properties. But there have been studies, bless you, there have been studies looking at antibiotics. There was an NIH-sponsored study called Cleanup IPF, where patients could go either on Bactrim or azithromycin, as I recall, and it was a totally negative study, unfortunately. There was data out of the UK looking at Bactrim as well. The initial study looked like it might do something, but a subsequent study showed that it didn't do anything. So while it makes intuitive sense and it should be an attractive option, it really hasn't been shown to work. There might be select patients where it might work. If patients get recurrent infections, certainly I don't see an issue with putting them on some low dose azithromycin. We do that in our transplant patients as well for its immune modulating properties, but there's no data to support that really.
So one question has come from the audience. It is about role of steroids in the exacerbation of ILD, including that in the scleroderma. The basis is that 2022 guidelines from ATS and American Rheumatological Association. They have said that you should use, or you can use, this is a conditional recommendation, that you can give steroids in CTD ILD other than scleroderma. So,
yeah.
One, exacerbation of ILD and steroids, and other is rheumatic disease.
So we all do that because these patients, especially the idiopathics and the IPS, when they have acute exacerbation, the prognosis is really dismal and you don't want to do anything. We throw antibiotics at them, we throw steroids at them, we give them pulse dose steroids, not because there's data to support it, but because you don't want to miss something that's potentially steroid responsive. And the results uniformly have been fairly dismal. There have been some patients who have turned around, the rare case that has turned around, and under the umbrella of acute exacerbations, there can be COP-like lesions that cause acute exacerbations that might be steroid responsive. So we do that. I think there's a greater likelihood of affecting reversal in the CTD patients because there's more likely to be an immune modulated or inflammatory component. For the CTD patients, and especially the myositis patients, because they tend to have more of these acute exacerbations, we will use high-dose pulse steroids, and we'll also layer on rituximab as well. And if there's, a large inflammatory burden, and we think, especially for the myositis patients, we might do plasmapheresis as well. So certainly these patients tend to be more responsive than idiopathic patients in terms of high-dose steroids.
So I'm asking you this about the last, because the time is coming up. The patient with ILD, advanced ILD, comes into the ICU with acute respiratory failure, almost requiring mechanical ventilation or NIV or whatever. So what kind of therapy we should offer to him after ruling out infections or whatever?
These are the toughest cases because the only therapy really that potentially can save that patient might be a lung transplant. But it's the minority of patients who are transplant candidates. And if they come in and they really on a high flow oxygen, we have to have that tough discussion about end of life issues and their wishes and desires, because if they go on mechanical ventilation, the chances of them getting liberated without a transplant are extremely low. So we try and discourage mechanical ventilation and just supportive care and palliative hospice care in those kind of patients, unless they happen to be lung transplant candidates.
In between, there has been a question from the audience. Can we diagnose HP, acute or subacute, in the absence of mosaic attenuation on CT scan?
I believe we can. Not every patient will have mosaic attenuation. And to me, this is where the history can be very helpful and perhaps even overwhelming in the context of making a diagnosis. I know we're going over time, but we just did a very interesting study with some French colleagues, and where we did a survey of various cases, 15 or 16 different cases. The pulmonologists were given the cases and then the HRCT. And sometimes the HRCT was misleading. And I'll explain by that. Let's take the same patient, 80-year-old male, former smoker, no connective tissue disease, no smoking history, family history of IPF. The pretest likelihood is 95% that that patient has IPF. And then you get a CT and it looks indeterminate or alternate diagnosis. And then you scratch your head and say, well, this can't be IPF. It looks like alternate diagnosis suggested. If you biopsy those patients, 50% of them will still have UIP, meaning even though the CT is the central diagnostic tool, sometimes the clinical will overwhelm the CT in terms of making the diagnosis, and one shouldn't get misled by a CT, even if it looks like alternate diagnosis, because if you biopsy those patients, you can still see chronic HP if you're suspicious of that, or you can still see UIP. So I think that's a very important message.
All right. So coming back to the exacerbation of ILD coming into the ICU, do you have any steroid dosages to tell me?
If we really want to be certain, what we do is we do high-dose IV methylprednisolone, either 500 to a gram IV daily for 3 days. That's how we treat acute rejection in lung transplant recipients. And that's how we will, if we really want to blast the patients, those are the kind of doses we'll give them if they really teetering on the edge and we want to be absolutely certain that they're not steroid responsive.
So I think you and me can go on for a very long time. I have so many queries, and so nicely you have been clarifying, and we have been able to take in between all the questions which came across, and it has been amazing listening to you once again. Every time I listen to you, I feel that I should have more of you. So that's what the feeling I have, and very patiently you have answered our sometimes some silly questions could have been there, but these are all based on our practice in India where we have limited facilities. Of course, you can discount the transplant facilities for the time being because they are very, very minuscule as compared to the volume of our physicians have immense interest in HP and CTD related ILD. So if I ask you a last question, one patient with ILD confirmed CTD is already on 2 immunosuppressive drugs like MMF and sometimes methotrexate along with some other biologics also. Now, when you do the CT, even as a routine, there are some interstitial abnormalities. So then you put them on antifibrotics in your wisdom. The patient gets bogged up with the bulk of medication that he gets. So how do you rationalize? I cannot ask my rheumatologic colleagues to reduce the medication for the CTD, and I cannot deny them medication that I know. I hope I'm putting a question which is
yeah. I think we all struggle with that, and the polypharmacy that stacks up for these patients, and before you know it, they have a lot of adverse events, and we're unsure what's causing the adverse events and what's helping them. It's very difficult, and especially to peel off medications in these patients with chronic lung disease, because there's this fear on the provider's part and the patient's part of, oh my gosh, what if I go off the methotrexate and my lung disease gets worse or my joints start acting up? So, it's very tough and it's case by case. It's hard to give specific guidance, but I think that we have to find that balance between what we think is working as well as the adverse event profile suffered by the patients. At the end of the day, we want to maintain these patients' quality of life as best as possible. And if we can't, and the medications are affecting that, then I think we need to sometimes be, brave enough to start peeling off some of these medications and just following the patients closely to make sure we're not doing any harm.
So one question has come from audience, so I'm constrained to take it. The question is, do all cases of organizing pneumonia need a biopsy, or we can do with the CT?
I think sometimes, honestly, you look at a CT and it looks like COP, chronic cryptogenic organizing pneumonia. It looks COP-ish. But you don't have biopsy of that. And I think this is where, I align with where you guys are in India in terms of having to take a pragmatic approach versus, an idealistic approach, because you have to work with what you have. I first want to be certain that there's no infection. And then I might treat them with steroids as I would a patient with biopsy, probe, and COP, and follow them very closely to see what the response is. If I really want to be certain there's no infection, I'll bronch them with or without a biopsy just to get washings and make sure there's no infection. It's not pneumocystis or some other infection that I'm missing. And then I'll treat them for their COP-like lesions with steroids plus minus MMF.
So, Mr. Nathan, it has been amazing opportunity and discourse of interstitial lung disease. I think we should have had at least 2-3 hours, of yours for that. And for that, I thank the Sun Pharma, who always promote academic activity without any, putting any pressure of any medication or anything. And I thank the audience for being with us. For me, it is an opportunity to learn further. And we'll keep troubling you again and again. Thank you. And
I enjoyed it. I thank you. I thank you as well. Thank you to Sun Pharma, Dr. Khilnani. Excellent questions. You could see I enjoyed it as much as hopefully the audience did. So I appreciate the opportunity.
I did force you to scratch your head a little bit in the morning. So that is a healthy discussion. So I hand over the podium
Yes,
or
doctor.
whatever. And
Yes.
thank you very much.
So firstly, a very heartfelt gratitude to both of you, Dr. Stefen, Nathan, and Dr. Khilnani, sir. We had for the last 75 minutes, we had a complete intellectual rigor and head scratcher questions, and a lot of where practicality and the entire objective of having a right approach to an ILD case and a very pragmatic inputs. We had a lot of insights, clinical insights to go and ponder upon. So I even thank all the audience who have joined for their being an August audience and being very interactive and asking questions and make the most of this opportunity. I hope we have unraveled the puzzle of ILD to an extent, but definitely going forward in a bigger way. So for now, thanks a lot for joining. Thank you, Dr. Nathan, for your lovely talk. Dr. Khilnani for driving the event. Thank you, team Sun and Exicon and our event partners. I declare the session to be concluded.
Have a good weekend, Doctor.
Have a great weekend.
Everyone there, have a good weekend as well. Thank you again very much.
Okay. Bye-bye.
Thank you.
Okay. Bye-bye now.
Bye.
Bye.